SBIRT, Screening, Brief Intervention, and Referral to Treatment, is an evidence-based approach to identifying patients who use alcohol and other drugs at risky levels with the goal of reducing and preventing related health consequences, disease, accidents, and injuries. In this presentation, we will specifically be focusing on alcohol use disorder. This is the most common and best documented form of abuse. However, the general approach applies to all forms of substance abuse. In order to effectively implement SBIRT into your practice, it's important to consider these aspects of substance abuse screening and treatment. When engaging with patients with substance use disorders, recognizing the attitudes you bring to the provider-patient interaction is an important first step. Next, understanding abuse as a medical problem allows you to approach it as you do other diseases. Understanding the frequency of substance use disorders among patients in a primary care setting justifies screening. And finally, a subsequent video will discuss a specific approach for assessing and treating the range of alcohol use disorder. This approach focuses on motivational interviewing and is generalizable to all forms of substance abuse, as well as other medical problems such as smoking cessation and medication compliance. Substance use disorders are often seen as a social failing rather than a medical disease. Considering alcohol use disorder, two prevalent models based on the idea that abuse is a social failing are the dry and the wet moral models. Some individuals approach alcohol use disorder from the perspective of the dry moral model, that is, just say no. The more common and more frequently advertised wet moral model suggests alcohol abuse is controllable and encourages responsible drinking. Both models are based on fallacies. The just say no dry moral model is predicated on the belief that alcohol and drugs are evil and those who use them are morally weak. This model promotes abstinence to avoid alcohol use disorders. The wet moral model suggests that everyone is able to drink responsibly, implying that control of one's substance use is possible for everyone. However, everyone can't use alcohol safely. 12 to 15% of Americans who begin drinking responsibly go on to develop alcohol use disorder. In addition, patients with a chemical dependency to alcohol are never able to use socially. Both models of alcohol use disorder as a social failing have fallacies. The best model for understanding substance abuse, including alcohol use disorder, is to see it as a medical problem. This model is supported by the fact that there is an established biologic mechanism, there are recognizable signs and symptoms, there are identifiable risk factors and predictable outcomes, and most importantly, alcohol use disorder responds to treatment. The CNS reward system is essential for all learning and memory and is influenced by multiple and varied life experiences, including drugs and alcohol. The experience you get when using a drug plays a large part in how much you use, control of use, and potential addiction. That is, this subjective experience can result in either greater feelings of reward or lesser feelings of aversion, which can then lead to the risk of abuse. Alcohol is thought to work via the inhibitory neurotransmitter GABA and stimulates the nucleus accumbens, which results in a decrease in aversive symptoms like anxiety. Drugs like cocaine produce feelings of greater reward by upregulating the pathways. Alcohol use disorder, like other medical problems, includes recognizable signs and symptoms: tolerance, dependency, withdrawal, and continued use despite negative consequences. Tolerance is the capacity of the body to become less responsive to a drug. Dependency means needing a drug to function normally, and withdrawal refers to the fact that abruptly stopping the drug leads to symptoms such as feelings of dysphoria and anxiety, and physical signs such as sweating, tremor, and increased heart rate. All of these lead to continued use of the drug despite negative physical and social consequences. Alcohol use disorder, like other medical problems, has identifiable risk factors such as adverse childhood experiences, ACEs, and a positive family history. The prevalence of ACEs is shown in this table from the CDC study done on 17,000 337 patients in the Kaiser Permanente system. In this study, 22% of the population had 3 or more childhood experiences in the categories of abuse, neglect, or household dysfunction. With 3 or more ACEs, the prevalence of moderate to severe alcohol use disorder was 27%, as compared to a prevalence of 8.5% in the general population. Thus, ACEs are a useful predictor of alcohol use disorder. As mentioned earlier in this presentation, there are many similarities between alcohol use disorder and other forms of substance abuse, including marijuana, cocaine, and opioid dependency. For instance, compared with people with 0 ACEs, people with 5 or more ACEs were 7 to 10-fold more likely to report illicit drug use problems, addiction to illicit drugs, and parenteral drug use. The ACE score has a strong graded relationship to the risk of drug initiation from early adolescence into adulthood and to problems with drug use, drug addiction, and parenteral use. Given a prevalence of 8.5% for alcohol use disorder, federally funded screening programs and the Department of Veterans Affairs recommend annual screening for alcohol use disorder. Up to Date in Medicine includes the following recommendation in their topic, Substance Use Disorders. Quote, "Clinicians should evaluate all new patients for alcohol and drug abuse. Drug and alcohol use should also be considered when patients present with new symptoms, recent motor vehicle accidents or physical trauma, mood disorders, weight loss, or ongoing unexplained symptoms." End quote. SBIRT allows identification not only of patients with alcohol use disorder, but also those who are risky users. 25% of the population will fall into the category of risky drinkers, and this group will incur more adverse consequences and costs at the population level. Most patients who fall into this category are unaware that they are putting themselves at increased risk for injury, interpersonal problems, and medical consequences. Multiple screening tools are available for use in primary care offices, some as brief as a single question during an interview. The audit, or Alcohol Use Disorders Identification Test, is an example of a more extensive, evidence-based screening tool. The audit is meant to be self-administered and scored, allowing patients to see where they fall in the spectrum of alcohol use. A score of 8 or more is consistent with at-risk use and informs the patient, quote, "You may drink too much on occasion. This may put you or others at risk. Try to cut down on alcohol or stop drinking completely." End quote. Some offices may prefer to use this tool as it helps the patient recognize a problem if they are in the pre-contemplative phase and sets the stage for a brief intervention by the healthcare provider. In summary, recognizing common attitudes about alcohol use disorder and acknowledging that it is a frequent medical problem supports universal screening in primary care offices. Check your understanding by taking the following quiz. Listen to each question, pause the video, and select your answer. Then listen to see if you are correct. Evidence supporting substance abuse as a medical problem includes which of the following? A, there is a biological mechanism. B, there are recognizable signs and symptoms. C, risk factors are identifiable and there are predictable outcomes. D, it responds to treatment. E, all of the above. The correct answer is E. ACEs, adverse childhood experiences, include A, emotional neglect, B, parental separation or divorce, C, physical abuse, D, all of the above. The correct answer is D. The prevalence of alcohol use disorder in the U.S. is approximately A, 50%, B, 1%, C, 8.5%, D, 85%. The correct answer is C. Go on to Part 2, SBIRT implementation.